You know that feeling, right? When you're just staring at a huge pile of notes or articles, maybe for exams, maybe just get your head around something complex. And you think, how do I even start to uh, make sense of this without getting totally
Well,
lost?
absolutely. Information overload is real.
Well, that's exactly what we're doing in this deep dive. We're taking your revision notes, the ones you shared with us, focused on one specific medical condition.
Yep.
And our mission basically is to dive into those notes together, cut through any extra noise, and just pull out the absolute must-know stuff, the high-yield points you really need.
Making it stick.
Exactly. So today we're zeroing in on seminoma. It's a type of testicular cancer, and everything we talk about is coming straight from your study material.
That's the plan. Think of it as us helping you build a clear roadmap from the info you've already gathered.
Perfect. Let's get started then. Your notes kick off with the basics. What exactly is seminoma?
Right. So fundamentally, your notes identify it as a testicular germ cell tumor.
Okay, germ cell tumor. And the notes kind of relate this back to the testicle's job, producing sperm from germ cells. So it comes from those like origin cells.
That's a great way to think about it. And the notes are specific. It's a malignant germ cell tumor. It actually looks like those very early sperm cells under the microscope.
Malignant, okay.
But here's a really key point right from the start in your notes. It's typically slow growing
Yeah.
and, importantly, often highly curable.
That's good to hear early on. Slow growing and highly curable, definitely high yield.
Absolutely. That sets the stage nicely.
So if that's the what, the next logical step in your notes is the why and who. Etiology and risk factors. Your notes mention the cause isn't always clear, often unknown.
Right. But they do highlight some important links. Specifically, genetic associations, Klinefelter syndrome is mentioned, and also cryptorchidism.
Cryptorchidism, that's
Yeah.
the undescended testicle, yeah.
Exactly. And if you think about it, conditions that affect chromosomes, like Klinefelters, or how the testicle develops, like cryptorchidism, it sort of makes sense they could increase the risk of those germ cells going wrong later. It connects the dots.
Okay, that connection makes sense. Genetic and developmental factors,
And your notes also mention environmental factors, exposure to certain chemicals, radiation.
which ties into the risk factors list where occupational exposure is noted, so potentially work-related.
Precisely. And then looking at that risk factors list itself, your notes add personal history, having had testicular cancer before, and family history.
Right, so genetics, development like cryptorchidism, previous cancer, family history, and maybe occupation, those seem to be the key flags from your notes for who's potentially at higher risk.
Those are the main ones highlighted, yes. So moving on from the why and who, let's look at the pathophysiology section in your notes. What's actually happening, inside the cells?
Okay, so your notes describe it starting with these abnormal germ cells. They just start multiplying uncontrollably, forming the tumor. Mm-hmm.
And reinforcing that earlier point, the notes say the growth is typically slow, often staying just in the testicle initially, localized.
Yes. And this section has another really vital piece of info, something that connects directly to why the prognosis is often so good. Your notes emphasize its high sensitivity to radiation and chemotherapy.
So it responds well to treatment.
Exactly. Your notes present this sensitivity as a key reason for the high cure rates. Understanding that helps make sense of the management strategies later on. It's fundamental.
Makes perfect sense. Okay, so we've got the basics down. Now imagine you're faced with a potential case. Your notes include a really important section on differential diagnosis. What else could it be?
This is crucial for revision, distinguishing things. Your notes structure this really well, splitting it into two main groups.
Okay.
First, other germ cell tumors. The list includes embryonal carcinoma, teratoma, yolk sac tumor, choriocarcinoma.
So other types of testicular cancer, basically. Yes, but specifically non-seminomatous germ cell tumors. And the critical point your notes make is that these are treated differently from seminoma. Knowing that distinction is vital.
Right. Seminoma versus non-seminoma. Got it. What's the second group?
The second group is non-cancerous conditions. Things like testicular torsion, epididymitis, hydrocele. Your notes point out these often present differently, like torsion and epididymitis are usually painful, whereas seminoma is classically painless.
Classically painless, yeah.
But, and this is a huge but, in your notes, you absolutely need proper investigation to be sure. You can't just assume it's benign based on symptoms alone. Diagnosis needs confirmation.
Okay, that's a really clear breakdown from your notes. Other GCTs needing different treatment and benign stuff needing proper investigation regardless.
Let's zoom out again. Epidemiology. How common is this? And who usually gets it, according to your material?
Your notes give some key stats here. It states seminoma is the most common type of testicular cancer.
Most common, okay.
And it gives a figure 40 to 45% of cases in the UK. That's a really useful number to remember for context. Almost half of all testicular cancers in the UK.
Wow, yeah. And the peak age range, primarily young adults, males aged 25 to 40, though your notes do add it can happen at any age.
25 to 40 is the main window.
Right. And interestingly, while the notes say incidence is rising, they also stress that the overall prognosis remains excellent.
Good. So most common type, young adults mainly, rising incidence, but great prognosis. Now, the practical side. Clinical features. How does someone actually, present? What do your notes say?
The classic description is a painless testicular lump or swelling. Your notes really emphasize that painless part as the most common finding.
Painless lump. Key phrase.
Definitely. Though other things are possible. A feeling of heaviness in the scrotum, sometimes rare testicular pain, rare being the operative word, and occasionally gynecomastia, which is breast enlargement.
Okay. Are there always symptoms?
Not always. Your notes mention some cases are asymptomatic and found incidentally, maybe during a checkup for something else.
Ah, okay. And if a doctor examines it?
Your notes describe the typical finding as a firm mass that feels like it's part of the testes, adhered to it. Sometimes there might be a hydrocele, which is fluid buildup, alongside it.
Firm mass, part of the testes.
But here's the critical point your notes make about clinical features, and we've touched on it. Symptoms and exam findings raise suspicion, but they don't confirm it. You need histopathological analysis.
Right. Looking at the tissue itself.
Exactly. That's non-negotiable for diagnosis,
Okay.
according to your source material.
Understood. So if seminoma is suspected, what investigations are done? Your notes lay out the steps pretty clearly.
First up is usually a testicular ultrasound. That helps confirm there's a mass and gives an idea of what it looks like.
Ultrasound first. Makes sense.
Then blood tests for tumor markers. Your notes list 3, AFP, alpha-fetoprotein, beta-HCG, beta-human chorionic gonadotropin, and LDH, lactate dehydrogenase.
AFP, beta, HCG, LDH. What do they tell you?
According to your notes, they help figure out the extent of the disease and how well treatment is working. It specifically mentions beta-HCG and LDH are useful for tracking the tumor burden.
Okay, so ultrasound, then blood markers. What's next for confirmation?
The definitive step mentioned is the surgery, removing the affected testicle. It's called an inguinal radical orchidectomy.
Right, the orchidectomy.
And your notes highlight its dual role. It provides the tissue for that essential histology, the definitive diagnosis, and it's the first step in staging the disease.
Diagnosis and initial staging via surgery. Got it.
Yeah.
How is the staging completed?
Your notes mention imaging to see if it's spread. CT scans of the abdomen and pelvis are common. Chest x-rays might also be done, especially if they suspect spread to lymph nodes in the chest.
CT scans, maybe a chest x-ray?
Yep. And staging uses either the TNM system or just a numerical system like stage 1, 2, 3, 3. But remember, the histology from the orchidectomy is what gives the final definitive diagnosis.
Okay, that investigation pathway is clear. Ultrasound, markers, orchidectomy for diagnosis staging, then scans for full staging. So once it's diagnosed and staged, how is it treated? Your management section breaks this down by stage.
Exactly. And that stage-based approach is key for revision. For local seminoma, that's stage I, where it's just in the testicle.
Yeah.
The first step is always that orchidectomy we just talked about.
Surgery first.
Always. Then, after surgery for stage I, your notes list the options as surveillance, which means monitoring closely.
Just watching and waiting.
Well, active watching, yes. Or a short course of chemotherapy, specifically mentioning carboplatin, or external beam radiation therapy to the sort of groin and pelvic area.
So surveillance, carboplatin, chemo, or radiation are the stage I options post-surgery.
Those are the options listed in your notes, yeah. The choice depends on various factors, but those are the pathways.
Okay. What about more advanced disease, stages 2 to 4?
For advanced seminoma, where it's spread, the primary approach listed is chemotherapy. Your notes specify platinum-based chemo, and even list the drugs in a common regimen: bleomycin, etoposide, and cisplatin, also called BEP.
BEP chemo for advanced stages. Got it. What if it comes back? Relapse.
Your notes covered that too. For relapse, it mentions salvage chemotherapy. And again, it lists the specific drugs used: mesna, vinblastine, ifosfamide, and cisplatin.
Okay, specific regimens for primary advanced disease and for relapse.
Yep. And just a practical point, your notes include the option of a testicular prosthesis or reconstruction after the surgery for cosmetic reasons.
Right, that's important too. Okay, so management is really stage dependent. Let's circle back to something we mentioned early on, the prognosis. Your notes seem pretty positive here.
Extremely positive generally, especially for that localized stage A disease. Your notes give a really powerful statistic here, definitely one to remember. The 5-year survival rate is over 95%.
Over 95%, that's incredible.
It really is. It tells you just how effective the treatments usually are for seminoma.
Does prognosis depend on anything?
Yes. Your notes list the factors.
Yeah.
The stage it's got it earlier is better, obviously, whether it has spread, metastasis,
Okay.
and how well the tumor responds to the treatment.
Stage, spread, and treatment response. Makes sense.
But even with that amazing prognosis, your notes correctly emphasize the need for regular surveillance afterwards. Follow-up is key to catch any potential recurrence early.
Good point. Which brings us to the potential downsides. Even with great outcomes, what are the complications listed in your notes?
Well, medically, there's the risk of recurrence of cancer coming back, and metastasis spreading to lymph nodes or other organs.
Standard cancer risks, okay.
Right. Then there are complications from the treatment itself. Your notes mention general treatment effects, side effects from chemo and radiation, and importantly, fertility issues. Losing a testicle, plus the potential impact of chemotherapy, that can affect fertility.
Fertility is a big one. Anything else?
Yes, and this is crucial. Your notes specifically include the psychological impact, the emotional toll on patients and their families. It's listed right there as a significant complication.
That's really important not to overlook. Okay, wow. We've really walked through your notes systematically. Definition, causes, risks, how it grows, what else it could be, who gets it, how it presents, investigations, management by stage, that excellent prognosis, and the potential complications, including psychological impact.
We have covered a lot of ground, using your notes as our guide.
So thinking about revision, how can someone best use this conversation, this deep dive?
Well, think about the structure we followed. We essentially pulled out the key lists from your notes. The risk factors, the differentials, remember seminoma versus non-seminoma, the investigation steps in order, the specific treatments for each stage, and the list of complications.
Focus on those lists.
Exactly. And those key stats, 40–45% prevalence, over 95% survival. Those are high-yield facts. Maybe make flashcards based on these sections, or draw a mind map linking the pathophysiology to the treatment sensitivity, for example. Use the flow we discussed to structure your own study of your notes.
Breaking it down definitely makes it feel more manageable. Okay, as we wrap up, let's leave you with a final thought, something that builds on what we discussed, especially those non-medical complications.
Yeah, we talked about the fantastic survival rates, the effective treatments,
Yeah.
but also the real challenges like psychological impact and potential fertility issues. So thinking about that whole person, the human side, here's a question for you to ponder. How might a more holistic approach to care, one that really integrates psychological support, fertility counseling, alongside the top-notch medical treatment, how might that further improve not just survival, but the overall quality of life and the journey for someone diagnosed with seminoma?
That's a really important question. Thinking beyond just the disease to the person experiencing it. Hopefully, this deep dive into your seminoma notes has been genuinely helpful, clarifying the essentials for you.
We really aim to distill the core information directly from the material you provided, giving you that solid framework for revision. You've got the key points now.
And if you are looking for more resources, maybe to supplement your notes, you might find MSRA.com and FreemSRA.com helpful. Those were mentioned in the context of revision tools.
Yeah, could be worth checking out. Keep up the great work with your studies, keep exploring, and thanks for diving deep with us today.
Absolutely. We'll catch you on the next deep dive.